इसमें होगा, यूट्यूब में होगा। इसके अंदर स्मेल क्या है जो आ रहा है?
पहले से ही
पहले भी LT3 में यही स्मेल आता था। शायद इसमें वायरस है। कैसा पता चलेगा कितना स्टूडेंट आया हुआ है? पता चल जाएगा? नहीं चलेगा।
अभी CR का सर मैसेज आया कि सर आ गया कि मैंने मुझे अभी चालू है।
नहीं चालू है अभी।
तेरह लोग आ गए
शुरू करें।
हाँ जी, हाँ सर आ गए। हाँ सर आ चुके हैं। ठीक है।
Okay. Today in this class we'll be covering some common ENT surgeries which we practice in our institute. Also, I'll try to mention some of the advanced surgery which we do here. So this is a very big topic, and it's difficult to complete all the surgeries in 1 hour. So we'll try to just touch the topic and give some important steps and which is important to that surgical procedures. So we'll come like a system wise: otology, rhinology, laryngology, head and neck, and some advanced surgeries. So first we'll come into the otology. Some of the important topics of surgery which we do for the otology are for chronic otitis media. So coming to tympanoplasty. Tympanoplasty is that surgery which we do for chronic otitis media, mainly the safe type. We do as such tympanoplasty. By the terminology, we mean that this is the repair of the ossicular status without repair of the ruptured tympanic membrane, and if there is a minimal disease in the middle ear, we try to clear that middle ear disease. So that is the terminology which we have it, which we use for tympanoplasty. So it will constitute three, like I mentioned, it will constitute three important parts. That is repair of the ossicular status, second is repair of tympanic membrane, and third is clearance of disease in the middle ear. So the indications are tympanic membrane perforation, conductive hearing loss, foot plate fixation, and ectatic or adherent TM, or what we call it as adhesive otitis media. So according to where we place the graft, we divide the tympanoplasty into different types. There are 5 types as classified by Woolstein. If we place the graft over the in this diagram, we can see that this is the malleus, this is the incus, and this is stapes, which is the foot plate is there in the oval window, and inferiorly this is the round window. And here what we see is the facial nerve canal. So if we place the graft in the handle of the over the handle of malleus, this is type 1, if the handle of Milius is necrosed and we place the graft over the incus, that is type 2. Type 3 is where we place the graft over the stapes. Either we use it a columella or we don't use it a columella, and then we place over the stapes is type 3. In type 4, the stapes superstructure is absent. So we have a concept that when the sound comes from the external auditory canal, it can strike into oval window as well as the round window. So if the same sound wave strikes into oval window and round window at the same time, the patient is not going to hear properly. So we need to create a phase difference. So in this, we don't cover the oval window. We let the sound strike the oval window. To create a phase difference, we put a graft over the round window. And type 5 is where the foot place is fixed. So even if we place a graft over the stapes, it's not going to help in transmission of the sound wave into the inner ear. So we create a fenestration and this is a lateral semicircular canal. So we create a fenestration in the lateral semicircular canal and we place a graft over the lateral semicircular canal. So when the sound strikes the graft, it goes into the lateral semicircular canal, inner ear vestibule, and it will go into the cochlea, and that's how the patient is going to hear. Or another thing, what they say type 5B is we remove the whole of the stapes and cover the oval window with a tissue, and we create a phase difference by covering the round window. So that is in brief about the from type 1 to type 5 tympanoplasty. In other words, type 1 is very similar to another term what we call as laryngoplasty. So laryngoplasty just means we repair the tympanic membrane, but we don't look into much of the ossicular status or the disease in the middle ear. But in tympanoplasty, we are going to look the other two things also. So briefly into laryngoplasty. Laryngoplasty also we have two types of laryngoplasty according to where we place the graft. So the graft what we place is we can take it from different areas, like we use most commonly is the temporalis fascia. That is the graft which we can harvest around the ear. So temporalis fascia is the most common one used. Second one is we use the tracheal pericordium, or the other graft which has been described is like a vein graft. So the two most common graft used is temporalis fascia and tracheal pericordium. According to where we place the graft, we divide laryngoplasty into two types, inlay and overlay. So this is the tympanic membrane, ruptured tympanic membrane. Peripherally we are going to have a fibrous annulus. If we place the graft over the fibrous annulus, then it's called as a overlay, and if we place it under the fibrous annulus, then we call it as a inlay. So to place the graft, what we have to do is first we have to elevate the tympanomeatal flap. Meatal means as meatus skin, tympano means the tympanic membrane, so tympanomeatal flap is elevated. Before that, what we need to do is we need to freshen the margin of the perforation. Why we freshen this margin is the concept of laryngoplasty or tympanoplasty of the to healing of the ruptured tympanic membrane is the graft is not going to stay there for a long time. This acts as a scaffold for the tympanic membrane to grow over it. So we need to freshen the margin. So once we freshen the margin and put the graft, then the tympanic membrane is going to start growing from the freshened margin. So the graft actually it acts as a scaffold. So we elevate the tympano after freshening the margin. We elevate the tympanomeatal flap, and in the inlay we are going to elevate the annulus too, and we are going to place the graft under the annulus. In the overlay, we are going to elevate the tympanomeatal flap, and the flap is elevated over the annulus, and we place the graft, and whatever the skin is there, we place it back over the graft. To support this from inside and outside, in the middle ear we have to put some gel foam, and outside too we have to put some gel foam so that the graft is stabilized. So the complications are, since we are dealing in the middle ear, any middle ear surgery, since facial nerve is very close in relation to the ossicular chain, so if the facial canal is dehiscent and we are not careful about manipulating the instruments in the middle ear, then we can injure the facial nerve. And second one is, if we are not careful and we don't maintain the strict OT sterility or surgery sterility, and it can end up causing perichondritis from where we harvest the graft, or it can cause hematoma. Chorda tympani is very much in close relation to the annulus, so we can injure the chorda tympani nerve. Even if it is injured in chronic CSOM, patient doesn't complain much of the taste problem, but in some patient they may come with altered taste sensations. And last but not the least, so any surgery, like any surgery, there is some failure risk. Second surgery, coming from first, we have come from the tympanic membrane surgery, then we will come to the mastoid bone surgery. So mastoidectomy is we open the mastoid air cells and clearing the antrum and clearing the mastoid air cells, all the mastoid air cells around the antrum. So the goal, this is mainly done for the mastoidectomy is mainly done for the what we call it canal wall up and canal wall down mastoidectomy. These are mainly done for the chronic suppurative otitis media unsafe type, and that is what we call it as a etico-infal disease. So the goal of unsafe CSOM is surgery in unsafe CSOM is eradication of the disease, first and the foremost goal, and after that we have to prevent the recurrence of the disease, and also if possible we need to restore the hearing. At least we should preserve it, and also if possible we need to restore the hearing, that is mainly the conductive hearing loss. So classification, we classified as canal wall up and canal wall down mastoidectomy. By canal wall, what we mean is the posterior canal of the EAC canal, that is the bone which is separating the EAC with the mastoid air cell system. So in the canal wall up procedures, there are different types of surgeries, like canal wall up mastoidectomy or combined approach tympanoplasty, simple mastoidectomy, eticotomy. Or in canal wall down procedure, the most commonly one followed is the modified radical mastoidectomy, etico-antrostomy, and bone dish surgery. So first I'll tell you about the modified radical mastoidectomy, just to clear the concept about modified radical mastoidectomy. So what we do is, modified radical mastoidectomy is we take down the posterior canal wall so that the mastoid air cells, antrum and the external auditory canal, they form a single cavity, so that if there is a recurrence of the disease, or if there is any disease which is left out while drilling the mastoid cavity, so while after it is healed, then the disease can be, the epithelium or the debris which is collected in the cavity can be safely drained out through the external auditory canal. So this is a more safer surgery than the canal wall up procedures. Simple mastoidectomy just means that we just remove the mastoid cortex and we remove the mastoid air cell systems depending upon the disease involved. So it can just range from limited air cell excentration to a more extensive clearance of the mastoid air cell system. Cortical is a more complete surgery than simple mastoidectomy. So this will involve more complex removal of the mastoid air cell system than the simple mastoidectomy. So this can also be accompanied with a facial recess approach, and this is also used as initial stage for any transmastoid surgery of the middle ear, inner ear, facial nerve, endolymphatic sac, or labyrinth, or other skull-based procedures. So as I said, modified radical mastoidectomy involves exentration of the mastoid air cells, opening of the antrum and attic, removal of posterior superior canal wall, and excessive socialization. And once we have made this much big cavity, we need to have a good meatoplasty so that whatever the debris is collected in that cavity is drained properly. The difference between modified and radical mastoidectomy is, in modified radical mastoidectomy, we try to preserve the hearing, and also we try to reconstruct the conductive hearing loss, whereas in radical mastoidectomy we don't consider much about the hearing loss. We are more into externalization of the middle ear disease. So this end up removing the, apart from removal of the mastoid air cell system, we'll also remove the mucosa and of the middle ear cavity, also the middle ear bones, that is malleus incus, and mainly the malleus incus. Stapes, we don't touch stapes foot plate. Also we'll try to close the eustachian tube, because here we are trying to be more safer than the modified radical mastoidectomy, and we don't consider about the hearing loss. So if we close the eustachian tube, if there is any infection in the cranial sinus or the nasopharynx, so the ascending infection to the middle ear can be prevented. The step of mastoidectomy, so it can be either done with a post-oral or the end-oral route. Here the diagram what we have given is the post-oral route. After elevating the skin, subcutaneous tissue, and once we go into the bone, then we give, there is a triangle known as a McEwen triangle, which is formed by the inferior temporal line, posterior superior canal wall, and the tangent of the external canal. This is the McEwen's triangle. This triangle roughly corresponds to the mastoid antrum. So if you drill through this antrum, through this McEwen triangle, we end up reaching up to the mastoid antrum. So once we reach the mastoid antrum, then we drill out superiorly and laterally, and try to identify the middle canal fossa, the bone which is separating the mastoid air cell with the middle canal fossa, what we call is as a tegmen. The anterior one is a tegmen tympani, and the posterior one is a tegmen mastoidae. And this is the dural plate. In the surgical term we call it as a dural plate, and posteriorly we define the sinus plate, that is a bone which is covering the sigmoid sinus. We drill anteriorly and we open the editus. This is the antrum. Anteriorly, if we do open up, we open the editus and then the attic, and the attic bone can be completely drilled. Once it is that done, then we lower the facial recess, that is the posterior superior canal wall, which is overlying the facial nerve. We lower it down up to the facial nerve canal. So we don't open up the facial nerve canal. We just make sure that there is a bone covering over the facial nerve canal. This is after lowering the facial ridge. And then so the complications of mastoidectomy. So since we are dealing close to the dura and sigmoid sinus and lateral semicircular canal, we can cause injury to it if we are not careful, and we can cause injury to the facial nerve, since we are dealing very close to the facial nerve segment, both to the tympanic segment as well as the that is the horizontal segment as well as the vertical segment of the facial nerve parts of the mastoid bone. And we can also, it can cause infection of the labyrinth, what we call as a labyrinthitis, which may lead to vertigo. Since while clearing the disease from the oval window, round window area, if we are not careful and rupture the oval window and the round window, then we can cause, it can lead to sensorineural hearing loss. Also, if you are doing an oral incision, or if you are harvesting a tracheal perichondral graft, it can cause injury infections of the cartilages leading to perichondritis. Later on, if you are not socializing properly, or if the meatoplasty is not that good, then it can lead to the cavity problem. Another important surgery of the ear surgery is Stapes surgery. The most common Stapes surgery what we do is for the otosclerosis, that is Stapedectomy or Stapedotomy. The indications of Stapes surgery is clinically suspected otosclerosis, in which the airborne gap is 25 dB or more in the frequency that is from 250 Hz to 1 kHz, and a negative RANI at 512 Hz tuning fork test. And if it is a bilateral involvement of the otosclerosis, then we operate the worst ear first. Contraindication is if it is the only hearing ear, that is an we cannot say absolute contraindication. It's a contraindication because already when we do a Stapes surgery, we manipulate the inner ear the inner ear is manipulated, so it can lead to the sensorineural hearing loss. So we don't want the patient to have the sensorineural hearing loss in the only hearing ear. Also, if there is infected middle ear and external ears, we don't want the infection to go into the inner ear, so we avoid doing Stapes surgery during that period. Pregnancy is a contraindication, Meniere's disease, and also active stage of otosclerosis, because during this stage, if we perform surgery, they are more vascular in the active stage, so it can lend into more bleeding during surgery. So the steps are, first, like a laryngoplasty, we elevate a tympanomeatal flap, that is external aortic skin below the annulus and the tympanic membrane, and we enter into the middle ear. After elevating it, after entering into the middle ear, what we see here is this is the long process of the incus. This is the handle of the malleus in which the tympanic membrane is attached, and this is the chorda tympani. So the chorda tympani was also retracted a bit higher up. So this has to be careful. Sometimes if we are not careful, then we can end up injuring the chorda tympani. After that, we dislocate the long process of the incus from the stapes head, and then we cut off the stapedius tendon. Then we cut the posterior crura, and the anterior crura can be fractured because the posterior crura is more thicker than the anterior crura of the stapes. And after doing that, so this is cutting the posterior crura. So after doing that, only the stapes foot plate will be remaining, and the long process of the incus. So there is a discontinuity between these two structures. To bridge that, we can use a piston. What we call is a process is a piston, which can connect to the long process of the incus to the stapes foot plate. If we remove the whole of the stapes foot plate, then this is the oval window. We can graft the oval window, and the piston can be placed over the graft. So this is known as stapedectomy. And if we make a hole here and then connect the piston from the long process of the incus to the stapes foot plate, the hole we have created in the stapes foot plate, that is called as stapedotomy. The benefit of stapedotomy is, since we don't manipulate the inner ear much, the chance of sensorineural hearing loss is less, so there is less complications. So nowadays the preferred surgery is stapedotomy rather than stapedectomy. So complications, since we are manipulating the inner ear, so it can cause sensorineural hearing loss. Since the facial nerve is very close to it, so this is stapes foot plate, and just above the stapes foot plate is a facial nerve. Sometimes the facial nerve canal can be dehiscent, and it may be prolapse over the stapes oval window area or stapes foot plate. So in such cases, if we are not careful, then we can cause facial nerve injury. Then coda tympani dysfunction, because we are also manipulating that. And since we are using this Teflon, this is a Teflon piston. Sometimes Teflon piston, it can cause foreign body reactions, and it can cause repetitive granuloma formation. And this can also lead to sensitive neural hearing loss. Sometimes if the piston length is very much longer, if you don't measure it properly, if it is longer, then it can project inside the inner ear and then stimulate the saccule, because the structure of the inner ear, which is close to this foot plate, is a saccule. So it can stimulate the saccule and can cause vertigo. Next surgery, important surgery in the ear which is done for hearing is cochlear implantations. This is mainly done for those type of hearing loss in which we cannot amplify with a hearing aid, like severe to profound hearing loss, and we have used hearing aid and there is no adequate benefit for 3 months. We can do it in the prelingual as well as postlingual. Prelingual, we have to do it when the child neuroplasticity is good, so that the speech can be developed after the child hears the sound. If we do it in the later stage, say after 10 years or 18 years, then the hearing loss, then the benefit of cochlear implant is going to be very less. The part of cochlear implant, we have 2 parts, the external component and the internal component. The external component consists of this is a magnet, and this is a processor, sound processor. This contains a magnet and the transmitting coil, and this sound processor will contain the microphone. And the internal component, this is the receiver stimulator package, and this is the electrode. This is the ground, the ball one is a ground electrode, and this is the electrode which goes inside the cochlea. And the aim is we want to place these electrodes in the scala tympani, either through the round window, or we do a cochleostomy just in front of the round window and then insert into scala tympani. By inserting into the scala tympani, what we want to achieve is we want to directly stimulate the whatever the nerve which is still functioning. So what we do is, first we make like a mastoidectomy. We do a cortical mastoidectomy, and we do a facial recess approach, and we enter into the middle ear, and we find the round window, and just in front of the round window we can do a cochleostomy, or we can insert the electrode through the round window. So once it is insert through the round window, it goes into the scala tympani in the basal turn, and it goes up to the middle turn. It doesn't go beyond that. The complication is, since we are drilling the mastoid bone and trying to reach to the middle ear through the facial recess approach, so we can damage the facial nerve. And since we are opening the inner ear, there is a risk of meningitis. Also, it can cause vertigo, and rarely the device failure can occur. This is very rare. After it, we'll come to the another system, that is rhinology. The important surgeries in rhinology, there are different important surgery or basic surgery. The first and the foremost is what surgery we do for the nasal septum. When the nasal septum is deviated, causing obstruction to one nasal cavity, or the obstruction, the deviation is causing recurrent sinusitis, because if the septum is deviated very laterally, it can obstruct the sinus outflow and cause recurrent sinusitis. Then there is an indication to correct the septum to bring it to the midline. So there are different surgeries for it. The most commonly done nowadays is septoplasty, and initially what we used to do is SMR, that is submucosal resection of the septal cartilage. So we know that the septum has got different parts, cartilaginous part and the bony part. What we do in septoplasty is we just correct the deviated part of the nasal septum, either the cartilaginous or the bony. Most of the time the bony part in the posterior part is more straighter than the anterior cartilaginous part. The one which causes more problem or obstruction is the cartilaginous nasal septum. If there is a bony spur which is causing obstruction, that also we need to remove it. So we can approach by giving different types of incision. The most commonly followed is either hemitransfixion or Freas incision or Killian's incision. Killian is we give the incision more deeper inside, whereas the hemitransfixion or Freas incision we just give it at the caudal end of the septal cartilage, quadrangular cartilage. After that we elevate the mycoperichondrial flap, that is the mucosa with the perichondrium, and directly it is the cartilage, and just remove the deviated part of the nasal septum or rearrange it so that the septum comes to the midline. In this picture what is shown is the major part of the septal cartilage has been removed, just preserving a significant part of the dorsal part of the cartilage septum and the caudal part of the cartilage septum. This is L strut. This is important to maintain the shape of the nose. If we remove more than this, then it can land up into depression of the nasal tip or the saddle nose deformity. So this much removal of cartilage is done in SMR. So SMR means it's a more aggressive surgery, removing this much part of the septal cartilage. So if there is a deviated nasal septum, after correction the septum comes into the midline. So the differences between these two is SMR is going to be more radical, like I have mentioned. Septoplasty is more conservative, and we prefer this, and this is the most common one which is followed nowadays. SMR is not done in children because it's radical, and septoplasty can be done in children also. Incision, SMR we usually do this Killian incision, whereas septoplasty we prefer to do Freas incision. Since we have to remove majority part of the cartilage, SMR we have to elevate flaps on both sides, whereas septoplasty can be done by elevating flap only on one side, preferably on the concave side of the deviated cartilaginous septum. Most part of the cartilage is removed, like I mentioned, whereas in septoplasty only the deviated, and we prefer to remove only small amount. Since we remove most part of the cartilage, there is more chance of septal perforation later on, whereas septoplasty, septal perforation, risk of septal perforation is less. Post-operative settling can occur in SMR, whereas in septoplasty we don't see saddle nose deformity. Since we have removed majority part of the cartilage, and while healing, both the mycoperichondrium is going to get thick and heal by scarring, so the revision surgery in SMR is going to be difficult, whereas in septoplasty revision surgery will be much easier. SMR we cannot combine it, means it's not usually combined with rhinoplasty, whereas septoplasty, for rhinoplasty we prefer to do septoplasty. Important complications are if there is bleeding and we don't control it, and we have closed the sutures, it can lead to septal hematoma that can cause infections, septal abscess, and after the abscess is, once there is infection, then the cartilage also can go necrose. The preserved cartilage, what we have preserved septal cartilage can go necrose, and this can lead to saddle deformity, and also septal perforation is a complication. Rhinoplasty. By rhinoplasty, what we call is usually this is a cosmetic surgery. In layman term, what we call it as a nose job. So the indication is depending upon the deviation of the external part of the nose, which we can roughly divide into three parts. The upper three parts, that is the upper third, middle third and the lower third. Upper third corresponds to the bony vault, middle third is the upper lateral cartilaginous part, and the lower third is the lower lateral cartilaginous part. So according to the deviation of this part, then of any of the part, we can there are different procedures to correct the deformity. Or if there is a hump nose, or if there is a saddle nose deformity or the tip deformity, all this can be corrected by doing rhinoplasty. There are two approaches: open approach or close approach. The preferred one is the open approach, because we can see the open approach just means that we give an incision over the skin of the columella, and the full of the skin, the flap, skin flap is elevated over the cartilage, that is this middle third and the lower third part of the nose. So this is an open approach. Close approach means we don't give this incision, we try to manipulate from incision, like we give Freas incision or clear incision, mainly the Freas incision. For the upper third deformity, since it is a bony deformity, we need to disengage the bone. That is, we do it by giving osteotomy, lateral osteotomy, and then medial osteotomy. We connect between this, and the whole of the nasal bone is freed so that it can be brought to the midline. Next important surgery is endoscopic sinus surgery. This is mainly done for uncontrolled chronic rhinosinusitis, which we have treated medically and it has not responded to medical treatment. Also, we do it for nasal polyposis, allergic fungal sinusitis, invasive fungal sinusitis, and also as a part of skull base, orbit or optic nerve surgery. For prerequisites for functional endoscopic sinus surgery, there are different terminology. FES is full form is functional endoscopic sinus surgery and endoscopic sinus surgery. By adding functional endoscopic sinus surgery, we mean that we want to preserve the function of the sinuses. That is, function of the sinuses means there are mucociliary clearance, that is the function of the mucosa of the sinuses. We want to preserve as much as possible, so we remove only the disease part of the mucosa and try to preserve as much normal mucosa as possible. This is called as a functional endoscopic sinus surgery. And if it is a more aggressive surgery, we are removing majority part of the mucosa, and we are dealing with removal of turbinates and or more extensive surgery, then we'll call it as an endoscopic sinus surgery rather than functional endoscopic sinus surgery. Before going for the functional endoscopic sinus surgery, the most important thing is we need to know the anatomy of the sinuses, what we are going to encounter during the surgery. This we can know it by doing imaging, that is a CT scan. Mainly what we do is a non-contrast CT scan paranasal sinus. We need to take all the three cuts, axial, coronal as well as sagittal cuts, to know the exact anatomy of the sinuses. What is the relations of the or the turbinates, what is the relation of the septum, and what is the anatomical relations of the sinuses with the skull base as well as with the orbit. All this information we need to get it from the imaging. Also, we have to have certain instruments apart from the camera monitors. We need to have certain instruments to perform this surgery. So when we go from anterior to posterior through an endoscope, what we are going to see first is inferior turbinate. Just deeper to it, what we are going to see is the uncinate process, and deeper to it, what we are going to see is the middle turbinate. Once we remove this uncinate process, once we remove it, then we are going to see this is the middle turbinate, this is the uncinate process. If we remove this uncinate process, we are going to see inside is the bulla ethmoidalis. And the space between the bulla and the uncinate process, that is known as the ethmoidal infundibulum. This is an important space because this is where most of the sinuses drain, starting from the frontal sinus, maxillary sinus, and anterior ethmoid. So if there is any disease in this area or any anatomical structures which is obstructing this ethmoidal infundibulum, this can lead to recurrent sinusitis. So just opening up the ethmoidal infundibulum sometimes can help us in draining the sinuses from the maxillary sinus, frontal, and the ethmoidal sinus. After the uncinate process removal, then we locate the maxillary sinus in this inferior part. That also can be widened so that the infection or the mucus can be drained easily from the maxillary sinus. Then ethmoid sinus, there is no clear-cut opening of the ethmoid sinus. So how we deal it endoscopically is just to remove the ethmoid sinus completely. That is anterior ethmoid and posterior ethmoid. After removing anterior ethmoid and posterior ethmoid, the posterior sinus, what we are going to encounter is the sphenoid sinus. So the sphenoid sinus ostium can be widened so that the infection, if it is the inflammation is involving the sphenoid sinus, that sphenoid sinus aeration also is improved by opening up the sphenoid sinus ostium. So this is how we see it. This is the middle turbinate, ethmoidal infundibulum. After removing ethmoidal bulla, after removing the uncinate process, this is the maxillary sinus opening. And after doing the whole exentration, the posterior most part, what we are going to encounter is the sphenoid sinus. And after opening up the sphenoid sinus, the last one we usually deal is the frontal sinus. Then coming for surgery of the tumors of the paranasal sinus, the benign tumor most commonly we encounter here is the angiofibroma or inverted papillomas, and the malignancy what we encounter most commonly is the maxillary sinus carcinoma. So this picture is just to show that there is a angiofibroma involving the maxillary sinus, involving the nasal cavity, and then pterygoparietal fossa, infratemporal fossa. Usually it doesn't involve the maxillary sinus, it goes behind the maxillary sinus. There are different approaches to deal with the tumors of the paranasal sinus. The open approaches are depending upon the extent of the disease. The limited involvement of the nasal cavity, maxillary sinus, can be dealt with the lateral rhinotomy approach. Lateral rhinotomy means we just give an incision, Morse incision laterally. We remove the part of the bone of the middle wall of the maxilla and the frontal process of the maxilla and enter into the nasal cavity, encounter the disease, and then remove it. This they have done a lip split incision. Usually lip split is not required. We can do without lip split. If it is a more extensive disease which is going into the infratemporal fossa, like angiofibroma going into the infratemporal fossa, we can do another procedure. This is a more extensive approach for a larger disease. What we call it as a maxillary swing approach, in which the whole of the maxilla is swung to the laterally, and the maxilla is left attached to the skin. So the supply of the bone is received from the skin, cheek skin, and we place it back again after removing the disease from the nasal cavity, nasopharynx, and the infratemporal fossa. And we can fix with the plates after bringing it back. to their normal position. There is also another approach which we don't get an incision over the face, what we call it as a mid-facial degloving. That is, we give a incision in the gingival-buccal sulcus on both sides and then elevate the cheek flap superiorly, and then we go into the maxillary sinus, and then we can go into the infratemporal fossa and then remove the disease. The problem with this approach is if the disease is going more posteriorly or superior posteriorly towards the sphenoid sinus or inferior orbital features, then sometimes it may be difficult with this approach. Superior approach exposure is difficult with this approach. Coming to the another topic in the laryngeal, another topic of ENT surgery is surgery for the larynx. So one of the important procedure what we do it in the operation theater is direct laryngoscopy. Like indirect laryngoscopy, what we do in the OPD, direct laryngoscopy is we try to visualize the larynx directly by going intraorally using a direct laryngoscope. Indication is, first and foremost important indication is laryngeal evaluation, biopsy and endotracheal intubation, or as a part of laryngoscopic tracheoscopic or bronchoscopic procedure, or as a part of microlaryngeal surgery. So microlaryngeal surgery, we try to do surgery by fixing the laryngoscope through the laryngoscope. That is, we do it like here. This is a laryngoscope, direct laryngoscopy, what we use it. There are different scopes are there, and in the scope what we have attached is this is a light source. This is a light we use to illuminate the tip of the laryngoscope, and this is also another type of the light source how we can attach here. So the laryngoscope is fixed like this using a laryngeal suspension. This is called as a laryngeal suspension. So using this instrument we can fix it like this, and these are the instrument, long instrument which we have to use it. The instrument should be long enough that we can use it through the laryngoscope and then do manipulation inside the larynx to do surgery. So how we do it is, so once we have done, this is the laryngoscope, once we have gone through the laryngoscope, there is a small vocal polyp is here. So we can hold with the instrument like this, and we can cut with the long scissors and then cut the polyp off. So why it is called as microlaryngeal surgery? Because we use a microscope to magnify the images, and then we can use the specialized instrument to do surgery inside the larynx. Another important surgery which we do in laryngology is thyroplasty. Thyroplasty is nothing but a laryngeal framework surgery which is mainly done for the voice. So there are 4 types described. Type 1 is medialization of the vocal cord. Type 2 is lateralization. Type 3 is we have to shorten it. Type 4 is elongation. By shortening it, what we achieve is we achieve the pitch to be lower. By increasing the length of the vocal cord, we tension it, so we increase the pitch of. This is for just to change the pitch of the voice. Medialization is the main one which we do it. Mainly we do it for vocal cord palsy. When there is a vocal cord palsy, the vocal cord is placed more laterally. This will cause a hoarse voice, and the patient voice will be low. So what we can do is, for example, say there is no polyp here, there is a vocal cord palsy. We can do through the direct laryngoscopy also. So we can inject the vocal cord with either fat or um, some other pre-med substances so that the vocal cord can be metallized. So that is also known as metallization thyroplasty. Or we can do it from outside by making a hole in the cartilaginous framework and then putting a prosthesis and then metallizing the vocal cord so that the patient voice can be improved. That is known as metallization thyroplasty. Another important surgery which is routinely done in otolaryngology is tonsillectomy. There are different indications, but the most important indication is recurrent tonsillitis and obstructive symptoms because of the enlarged tonsil causing obstructive sleep apnea. So if these two symptoms are there, then we need to undergo surgery. And as a part of malignancy, if there is suspected malignancy, then we need to do the surgery. The other indications are relative indication for tonsillectomy. So contraindication, if there is a bleeding disorder, submucosal cleft, baropharyngeal insufficiency, if there is acute infection, we don't do it. If there is anemia and extreme ages, we don't do it. So there are different methods, cold and hot method. By hot we mean that we use some instrument to cut the tonsil off, either electrocautery, laser or radiofrequency. Whatever may be the methods, the most routinely used method or the most preferred method is the cold method, because this is the cold dissection method is the most important one by the cold instrument, because this causes less pain and less and faster healing postoperatively. So cold dissection is, we use a cold instrument, guillotine, microdivider, harmonic, plasma, cryotherapy. Though plasma mediated ablation, what we call it as a coablator, these are all described and we use all these instruments also, but what we prefer is a cold dissection method by cold instrument. For doing this tonsillectomy, we need to put the position into neck extension as well as the head extension. This is achieved by putting a soldier pad and a neck roll. And once we expose it, these are the different instruments what we use it. The tonsillar dissector, snare and tonsil holding forceps. We need to hold the tonsil. This is uvula, patient is lying down and then the tongue is retracted upward with a Boyle-Davis mouth gag. So, and the uvula is here. So once we hold the tonsil with the tonsil holding forceps, hold it and pull it medially. We can see the anterior tonsillar pillar. We can cut with a cold sickle knife along the anterior tonsillar pillar and then use dissector to dissect off the tonsil just outside the capsule. Once we reach the inferior pole, because most of the blood supply comes from the inferior pole, we use this snare to cut off the inferior pole, because snare crushes and then cut it, causing bleeding to blood vessel to occlude. Indication of adenoidectomy: obstructive sleep apnea because of enlarged adenoids, or if there is a persistent serous otitis media. So we can use either a curate method or we can use coablator. That plasma mediated, what we say is that we can use the coablator to ablate the adenoids, or we can use this curate just to curate off the adenoids. So main complication is bleeding, both intraoperatively and postoperatively. And postoperatively, another important complication or sequelae is pain. Same for the adenoidectomy. So another important procedure or surgery is tracheostomy. So there are different indications. First and the foremost indication is prolonged mechanical ventilation. That is, a patient which are there in the ventilator in the ICU. We cannot keep the endotracheal tube for a long time because pulmonary toileting is difficult. There is risk of tube block, and the most important thing is if we put the tube in the trachea for long duration, the tube cuff itself can cause injury to the trachea, causing tracheal stenosis. That we don't want it to happen, so we can convert it to tracheostomy. Another important indication is pulmonary toileting, as well as a part of procedure in head and neck cancer surgery or extensive maxillofacial fractures, or if preoperative surgery, if the patient has got trismus and we cannot intubate, intubation is difficult even with a fiber optic laryngoscope, then we have to do tracheostomy. Also, airway obstruction, which is commonly seen in like carcinoma of larynx. When there is an airway obstruction, we need to secure the airway by doing tracheostomy. Steps is we need to extend like tonsillectomy, extend the neck as well as the head, so that the whole of the larynx and the trachea is pushed upward. This is the hyoid laryngeal framework, cricoid level, and this is the suprasternal notch. We give the incision roughly at the midpoint between these two points, that is the cricoid and the suprasternal notch. A horizontal incision or the vertical incision can be given. Mainly preferred is a horizontal because the postoperative cosmesis, once we remove the tracheostomy, the cosmesis is better. After giving the incision, then we need to go through the skin subcutaneous tissue, then investing layer of the cervical fascia, then we reach the strap muscles. We retract the strap muscles, that is the outer strap, and the inner strap, that is the sternohyoid and the sternothyroid muscles laterally on both sides, and we reach the once we retract these strap muscles, what we encounter is the thyroid isthmus. The thyroid isthmus can be either cut in the midline or it can be retracted upward. Then we encounter the tracheal cartilage or trachea. We need to confirm it by using a needle and then aspirating it, and after giving a stoma we can see a endotracheal tube here. The endotracheal tube is pulled upward and we can insert the tracheostomy tube. So there are different complications for tracheostomy. The most important complication is postoperative bleeding. If you don't do the hemostasis properly, there can be bleeding postoperatively. Also, another important complication is if you do a low tracheostomy, sometimes the apex pleura comes upward and the patient is struggling, and we try to retract it laterally, we can injure the pleura, causing pneumothorax. And also, if the patient is coughing post-operatively, it can cause subcutaneous emphysema. There are different head and neck surgery. This itself is a very big topic. I'll try to cover only very few head and neck surgery which are important. One is neck dissection. There are different level of neck dissection, as we know, starting from level 1 to level 7. Mainly in neck what we see is till level 6, 1A, 1B, submental, submandibular, 2, 3, 4, depending upon the lower border of the, these are the anterior jugular chain. So depending upon the hyoid and cricoid, above the hyoid is 2, between hyoid and cricoid is 3, and hyoid and clavicle is 4. Cricoid and clavicle is 4, and behind the posterior border of the sternomastoid is level 5. So there are different level of dissection. What we call is supraomohyoid is clearance of level 1, 2 and 3. Posterolateral is 2, 3, 4 and 5. Lateral is only 2, 3, 4. That is what we also call as anterior jugular clearance. Radical and modified radical is clearing from level 1, 2, 3, 4 and 5, and central compartment clearance is level 6. What we do it in thyroid surgery. So this is after clearance of modified radical neck dissection, after clearance of level 1, 2, 3, 4 and level 5, and we have preserved the IJV, and we have also preserved the spinal accessory nerve, and this is the digastric. Another important surgery is thyroid surgery. There are different types of thyroid surgery like hemithyroidectomy, lobectomy, subtotal thyroidectomy, near total thyroidectomy and total thyroidectomy. And the important structures which we need to encounter in thyroid surgery is superior thyroid pedicle, inferior thyroid pedicle, and two important structures, that is parathyroid and recurrent laryngeal nerve. If we can deal with these structures, then the thyroid surgery will be simple. Maxillectomy, this is mainly done for maxilla surgery, and in total maxillectomy what we do is we try to remove the maxilla as a single bone by disengaging from the frontal process of the maxilla, zygoma and the palate, and also posteriorly from the pterygoid process of the sphenoid bone. So this is the maxilla. So after we give a cut in the frontal process of maxilla, zygomatic process of the maxilla and the midline. So after removing it, this is a post op cavity which we can reconstruct using a free flap like a fibula, or most commonly what we use is we use a prosthesis to cover this area. Laryngectomy, total laryngectomy, which we do for advanced laryngeal cancer, dysfunctional larynx, that is, or stage 4 laryngeal cancer, in which we remove the larynx as a single compartment. Along with larynx, what we remove is also the strap muscles, hyoid bone, and also one part of the thyroid lobe, and the pharynx is open, which we need to suture it primarily. So this is how the larynx specimen is removed. Once the larynx is removed and the patient needs to communicate, they can speak by using a prosthesis which is known as a tracheoesophageal prosthesis. This is a device which acts as a one-way valve. When the patient breathes and we occlude the stoma, the breathe out, the air goes through this processes, go into the pharynx vibrate and then produce voice. And when the patient swallow, the liquid doesn't come into the trachea because it's a single way valve. So this is a tracheoesophageal prosthesis which we can use to rehabilitate the patients after total laryngectomy, or we can use electrolarynx or esophageal speech. Some surgeries for the oral cancer, because oral cancer is the most common cancer in India, in head and neck, and this can involve the mandible or the tongue. And if it is involved the mandible, then we can, if the tumor is going close to the mandible, to take a margin, we can do a marginal mandibulectomy, or we can cut the mandible out as a segment. What if the mandible is involved? This is known as segmental mandibulectomy. This is after doing modified radical neck dissection, that is type 2, preserving the IJV and the spinal assisted nerve, and segmental mandibulectomy, what we call it as a composite resection or commando surgery. So there are some newer advances which I would like to mention. The list of otolaryngology surgery are extensive, and it's difficult to include all the surgeries. Some newer advances like robotic surgery, which we do for the oropharyngeal surgery. Previously what we used to do for the oropharyngeal surgery, we split the mandible, what we call as a mandibulotomy, and then access into the oropharynx. This can be avoided by using robotic instrument, because they have got a finer arm and it can reach into the pharynx and then manipulate inside the pharynx and then remove the tumor from there. They are also, in terms of reconstruction, there is also something called as microvascular reconstruction, in which what we do is we harvest the tissue from another part of the body and put it into the head and neck, into the surgical defect, so that the morbidity is less. For example, in this patient, if the anterior arch is resected, the patient will not be able to swallow, and the dental alignment is also going to go off, and patient is going to have a bad deformity known as endogum deformity. So we can harvest a bone from the leg, lower leg, usually fibula, and then put it here into the surgical defect, and the fibula is supplied by peroneal vessels, which can be anastomosed in the neck. So this is a vascular flap, and later on we can use dental implant to rehabilitate this area. So the patient can also chew in future by using a dental implant. Thank you. If there is any doubt, you can contact me, and about the surgical procedures, if you want to, these are some important topics. If any topics which you feel is interesting and you want to know further into the topic, you can contact me, and I can clarify your doubts. Thank you.